We continue with the flow of keynote addresses, and the next in the pipeline is for the role of renal denervation in hypertension today. This keynote address is to be delivered by Professor Arup Dasbiswas from Kolkata, West Bengal. Before he is invited formally, may I invite the chairpersons in the order of appearance, Drs. A.K. Kaushik, A.K. Gogna, R. Hotchandani, S.K.D. Bharadwaj, and Vittal Gupta. Professor Dasbiswas will have 13 minutes for his presentation, and that will be summed up by the chairperson's comments only. Being a keynote address, we will not be having any questions from the floor. I request the chairpersons to kindly invite Professor Dasbiswas.
Thank you for inviting us to chair this keynote address. So hypertension is a real important disease in Indian scenario. It is increasing, and our success rate in controlling hypertension is only 12 to 13%. But we will hear what we can do in resistant hypertension or to prevent hypertension so that patient may not be required to take long-term medication. So I invite the speaker for his keynote address. Thank you.
Good morning, everybody. Thank you, dear chairperson. At the outset, I would like to thank the organizers for giving me this opportunity to speak before you. We are dealing with a new kind of therapy for the resistant hypertension, which is almost one-third of the patients that are suffering from resistant hypertension. And the pure study now highlighted the importance of hypertension as a big group, big chunk. So when we call it resistant hypertension is that when the patient is not responding to 3 or more drugs of different class to hypertension, his BP is not under control even after 3 or more drugs of different class. So this is forming a large chunk, almost one-third, and may vary from 10 to 30% in different studies and trials. The PURE has also highlighted this issue, and from various trial data what we find that in major trials, hypertension, there were many people who could not be controlled adequately. So there has been a very good connection between the sympathetic nervous system and hypertension. This is well known, and the different preventive trials, as also highlighted by Dr. Gupta just now, that also reflects to some extent the connection between the sympathetic nervous system and the stress and the hypertension and other kinds of cardiovascular disease. So this has been tried, and we know this pyramid, how the sympathetic activity, obesity and aldosterone ultimately leads to resistant hypertension. This is the diagram, what is the communication between the central nervous system and the renal sympathetic nervous system. The renal sympathetic nervous system, which is arborizes around the renal arteries, has got two ways. One is afferent, another is efferent. Both are important for when we consider management of hypertension. This is a more simplified diagram where you see the renal afferent system as well as the efferent system, and this ultimately leads havoc upon the cardiovascular territory, sleep disturbance, vasoconstriction, atherosclerosis, insulin resistance, metabolic disorders, etc. So this has been a thought, not very new. Almost since 1930s, people have tried to tackle hypertension and other kinds of problems by sympathectomy. And surgical sympathectomy has been successful in lowering hypertension. But they were effective, but there was significantly morbidity was there, it was difficult to perform, and there were many side effects. So this didn't become popular. So a simpler, more elegant solution, catheter-based, of renal denervation has now come into vogue. This is having less of side effects, so we will focus upon that. It is more localized, minimally invasive, and provides short procedural and recovery times. In this way, this has to stay. So this is the diagram of the renal innervation, and they remain mainly on the adventitia. And when we send some radio frequency current from here, energy, these afferents and efferents, they are destroyed, and they are mainly arising from the territory of T10 to L2. And they, after destruction, it leads to certain changes we'll be coming to discuss. So this is how it is done. A catheter is placed from distal to proximal and pulled, and in a circumferential way, in a rather spiral way, because it's a more cylindrical in nature, in different areas, starting from inferior, lateral, infralateral, superior, superlateral, from distal to proximal, different points are touched upon and ablated by the radiofrequency energy. This is the more intimate diagram of what is being done. And this is done by a special catheter which can be rotated in different directions and flexed also for intimate contact. And this contact is verified by not only the visualization in the fluoroscope, but also by impedance measurement. There have been two large-scale trials in the initial evaluation. First in man has been the pilot studies with the Symplicity HTN1, then Symplicity HTN2, and Symplicity HTN3 is undergoing in different parts of the country. So just to summarize a few aspects of the Symplicity HTN1, the patients selected were the resistant hypertension as defined, and one of the drug was a diuretic. They were having normal kidney function. The patient's characteristic in the control group and in the study group, they were well matched and had different kinds of patients, different populations of patients. There was what was revealed, that significant and sustained BP reduction. This was significant, 20 to 10 in the systolic and diastolic group fall, and that was consistently and persistently preserved for 24 months of follow-up, and gradually the decline was more evident as well. This BP reduction, this persisted through 3 years of follow-up, and as I showed you, gradually it became more and more effective as time passed away. And it's not only that, initial responders, rather I should say initial non-responders, ultimately were converted into responders. So initially what was observed, suppose you look at the initial part, there was almost 30% non-responders, but at the end of the 36 months follow-up, 100% were responders, and this was revealed from 12 months onwards. So there may be a group of late responders. So this also revealed, and it was relatively safe. Only one person went into renal artery stenosis, but this was not directly related to this procedure. So conclusion was from the Symplicity HTN1 is that the magnitude of clinical response is significant and sustained through 3 years. Increasing responder rates indicate no loss of treatment effect out to 36 months, and BP non-responders at 6 months does not predict failure to respond at 12 months or later. Now we come to Symplicity HTN2. It was almost 100 patients divided equally, and the study was taken up in different countries of Europe, Australia and New Zealand. There have been the different exclusion and inclusion criteria. For lack of time, I'm skipping those things. Just I'm showing the results. Again, these groups were closely matched. The maintenance of the BP reduction was significant and consistent and persistent in both systolic and diastolic subgroup. And not only that, in this design, some of the patients were allowed to cross over to control from the initially to the control to the study group by doing renal denervation. And here you can see that this group also responds. Suppose these were the control group, after they were subjected to renal denervation, they also responded by significant lowering of blood pressure. This is important to reveal. So BP reduction was sustained for 18 months, both for the crossover group and the pooled group was successful, and the renal function was not deteriorating, it was maintained well. And safety record was also impressive, and the impressive procedural safety in an expanded cohort of treated patients, minor adverse events that included femoral artery pseudoaneurysm that can happen with any femoral arterial puncture procedure. One patient had procedural BP drop resulting in prolonged hospitalization, but his condition could be stabilized by just lowering the antihypertensive drugs. So there was no significant complication with him also. So only the Symplicity renal denervation system, that is the renal denervation I was describing, the flexible and the soft tip design is successfully demonstrated. I'm not going into the procedural details for lack of time. Rather, I'll go into certain other benefits that have been shown into the recent results. For example, they have shown the spilling over of the different neurohormones that was less. Muscle sympathetic system nerve activity was also less after this procedure. So interventions in hypertension with renal sympathetic denervation reduces left ventricular hypertrophy. This is another demonstration. They have shown different parameters of left ventricular thickness, muscle mass. This was significantly reduced with this procedure of denervation, and not only that, diastolic function also improved. So besides the known effect on blood pressure, this study showed for the first time that renal denervation significantly reduces the LV mass and improves diastolic function, which might have important prognostic implication in patients with resistant hypertension at high cardiovascular risk. Now, one or two presentations from ESC. Then this was shown that there has been improvement in the cardiac function. They have shown different parameters in cardiac stiffness and the arterial stiffness. The arterial stiffness has improved, and they showed that significantly improved peripheral and central blood pressure. Pulse wave velocity improved by almost 1 meter per second. That means almost rejuvenation for coming 10 years. And other study has shown that ventricular systolic parameters improve, ejection fraction improves, and end diastolic volumes decrease. So heart failure and systolic dysfunction are associated with poor prognosis, and there increases this renal sympathetic denervation improves this subgroup also. It's not only that, they reduce stress and help in stress. So anxiety, depression, quality of life, and stress in patients with resistant hypertension before and after denervation has been studied by a subgroup, and that significantly reduces office blood pressure. Safety method and psychological processes are positively influenced, and they also improve headache in certain patients. ESC 2012 also highlighted the issues on Symplicity HTN2, and this has also been well acclaimed. And the other roles now are being evaluated. I think they need some mention. They are improving the metabolic syndrome patients. They are helping in glycemic control. They are helping in sleep sleep disorders, mental stress reduction, LVH regression, heart failure improvement, and reduction of arterial stiffness besides blood pressure lowering. So another promising addition, this is another promising addition to the therapeutic armamentarium of resistant hypertension. An actual role in regular clinical medicine is yet to be established by larger studies. I have quoted at only certain small sets of patients. We need all the worldwide over larger studies. Thank you very much for patience hearing.
Thank you, Dr. Biswas, for taking us the journey through this newer modality. In fact, hypertension is a lifestyle disease and needs lifestyle intervention for most of the patients, as Dr. Gupta in previous lecture has told us. So that is what India needs. But definitely in a small subset of patients where all the factors have taken care of, still the patient doesn't have control of hypertension. This modality is the upcoming modality. Definitely it has to establish its role. I must compliment for your lecture. Thank you.
Thank you for your comments. Definitely this is a small subset where only we can deal with.
Thank you very much, Dr. Biswas. very nicely, but I wish to know one thing, that before trying this procedure, why not to try this 3D method, what we are learning here? And
these patients have not been tried with 3D. Of course, they were tried with lifestyle and other medications, not this 3D, yes.
Because it will further reduce.
Hopefully so, hopefully so.
And secondly, sir, I wanted to know what would be the cost of this procedure, because in India, I don't think majority of the people would be able to afford it.
Accepted. It will be almost about 50 to 60,000 per patient, yes, one-time cost.
Thank you.
Ladies and gentlemen, as an honor to the invited keynote speaker, Professor Arup Dasbiswas, may I invite our chairpersons to kindly don him a medallion and a citation. Thank you very much, gentlemen. We keep our progress with the keynote address.